My pleasure to introduce Professor Jeremiah Chakaya to give us this webinar. Professor Chakaya is no stranger to KNH. I first met him when I was a registrar in our chest unit many years ago. So Chakaya is a professor of global respiratory medicine. He's also a founder member of RISOC, the Respiratory Society of Kenya. He's also a prominent pulmonologist in this town. He did a lot of work in Kemri in TB, and he talks a lot about TB. I think he's held many posts in the union, the International Union Against TB and Lung Diseases. So I'm sure he'll have a lot to tell us. So my pleasure to welcome him to give us this talk. I'm sure you'll enjoy it. Thank you. Hello.
Yeah, thank you very much, Dr. Atina. Great to see all of you here. I didn't know that this session was going to be attended by so many people, but at the last count, I had almost 700 people viewing this, which is really great. Thank you for the request to speak about tuberculosis and specifically to talk about how to identify all people with tuberculosis. I'll start by telling you that I don't have any declaration of interest to provide to you in relation to this presentation. I didn't know that you are beginning to start a series on tuberculosis, which implies that maybe what I had planned today to speak to you about today might end up encroaching on what others were going to say in future sessions, but it doesn't matter. I think I'll go to wherever I can go and others can take those topics into greater depth when their time comes. So I will cover in this particular talk an outline of the burden of disease, some of the issues around screening, give you an update a little bit on where we are with diagnosis and treatment, including treatment of latent TB infection. So let's quickly look at the burden of tuberculosis. We need to look at our country in relation to what is happening in the rest of the world. And many of you will know that the World Health Organization comes up with a global TB report every year. The most recent report was or came out in 2021. In that report, it was estimated that the year before, these reports give you data on the year before the year when the report comes out. So the 2021 report has got data for 2020. And in the year 2020, it was estimated that about 10 million people developed TB across the world, and about 1.5 million people died of the disease. If it wasn't for SARS-CoV-2 and COVID-19, tuberculosis would have remained the #1 cause of death from a single infectious disease globally. But in 2020 and in 2021, that position was taken by COVID-19. Now, assuming that COVID-19 is going to be beaten and is going to be thrown out of this world through many things, including vaccination, tuberculosis may occupy its #1 position as the most common cause of death from a single infectious disease. So let's turn on now to the problem of tuberculosis in Kenya. And I'm going to really highlight to you the data that was presented by our country through the National TB Control Program to the World Health Organization. So I won't be giving you the most recent data for 2021 up to 2022. In terms of estimates, this is what was estimated to be happening in this country, that in 2020, we had nearly 139,000 people who developed TB in this country, with, of course, a range of anything between 86,000 to 205,000. Among those were people who had HIV, who were HIV positive, and that accounted for about 35,000 people. while those who are HIV negative, in terms of mortality, those who are HIV negative, 21,000 people were estimated to have died of TB, which is a lot of people. And among those who are HIV positive, the estimate was that 12,000 people died of TB in 2020. There's a parameter called TB treatment coverage, which provides an estimate, or rather provides an indicator of how many people who had TB in a particular year were identified and treated vis-a-vis the total number of people who had TB in that year. Now, if you look at our data that we presented to the World Health Organization, and assuming that the estimate of 139,000 people developing TB in 2020 is correct, then we have a big problem, because in 2020, we only identified 50%, nearly 50% of the people who had tuberculosis in this country. The other 50% were either not identified or they were not reported to the National TB Program, and that's a real bad performance. In terms of real numbers, the number of people with TB that we reported to WHO in 2020 is provided in this table. We had 71,646 people with TB. 70% of those we tested using what is called a rapid molecular diagnostic test, like EXPERT. Nearly all of them, we knew their HIV status. 86% of these individuals had pulmonary TB, and that's why the pulmonologists tend to think of tuberculosis as their disease, because a lot of people with TB have pulmonary disease. We confirmed nearly 70% of these individuals. In terms of those who are children under the age of 14, we had 8%. And if you look at the percentage of these individuals who are women over the age of 15, we had 31%. So again, tuberculosis is mainly a disease of men for reasons that is not completely understood, or are not completely understood. If you look at the age and sex distribution of tuberculosis in this country, and again, this is what we reported to the World Health Organization, the bulk of TB is found in young males. So if you look, these are the males and these are the females, and it's mainly young males who are affected by tuberculosis in our country. If you look now at the drivers of TB, what is driving tuberculosis forward in this country? There are largely 5 key factors that are driving tuberculosis in this country. The first one being undernutrition. A lot of people in this country have no access to food, which many of us take for granted, and are therefore undernourished. And because of that, the population attributable fraction of TB that is caused by nutrition is very, very high. The net is actually higher than the HIV as a driver of tuberculosis. Alcohol use disorders are a common risk factor for tuberculosis. Smoking and diabetes also contribute to the burden of tuberculosis in this country. But I think the key thing here is undernourishment and HIV are the 2 things that if we could do something about, maybe we would reduce the burden of TB in our country. So if you look at how well we did in terms of treating our patients with TB, and this would be for the cohort that was reported to the national program in 2019, we had a treatment success rate of 86%. Now that might sound good, 86% of people with TB were treated successfully, but ideally it should be 100% of all these individuals. And if you don't really get there, you should not accept anything below 95%. So we are not doing as well as we should be doing. You will see 100% there for people who are treated for XDR TB, but it was only 1 patient that was notified to the World Health Organization in 2019 and who was successfully treated for MDR and for XDR TB. Treatment success rates for those with the MDR TB are not that good. we managed only to successfully treat 74% of those that we picked up in 2018. I think I'll move now to the impact of COVID-19 on TB case notification in 2020. Fortunately, we seem to have recovered and the numbers are creeping up again. But if you look at the centerpiece here, TB case notification was increasing. It reached a peak around 2019 and then dropped to only 70,000 people in 2020. And this is attributed mainly to the effect of COVID-19, meaning that a lot more people were missed with TB in that year, and therefore a lot more people probably died of the disease. So let's move on now to look very quickly at those who are at risk of TB and therefore who need to be screened regularly for this disease we call TB. This is the epidemiological framework for TB control purposes. You get exposed to TB, Mycobacterium tuberculosis. Exposure does not necessarily mean you will get infected, but some people get infected. If you get infected, you can then progress to active TB disease. That can happen within a short period following infection, usually under 2 years, which we call primary TB, or you can develop tuberculosis many, many years later, which we call reactivated or post-primary disease. Those who have LTBI are those individuals who have infection with Mycobacterium tuberculosis, but do not have clinical signs or symptoms of the disease. So who is at risk of tuberculosis? And we can divide these populations into 3 levels. Those that are at the community level and those that are at the facility level. At the community level, these are the individuals that are at an increased risk of exposure to TB, and because they may be alcohol abusers, for example, or have drug alcohol use disorders, or because they have malnutrition or they are smoking and other things, they can then rapidly progress or they can progress to active TB. So those who are living in geographical areas with a high TB prevalence, in the city of Nairobi, this would mean the slums of the city. Those are the geographical areas where there's a lot of TB transmission. Those who have poor access to healthcare, the homeless, nomadic population, and those who are contacts of people with TB. If you look at the clinical service area, like at the Kenyatta National Hospital, if you're working there and you are addressing TB, you will be very interested in these groups of individuals. Previously treated people with TB can get recurrent TB, and therefore one has got to keep watching them to be sure that they do not have recurrences of the disease. People who are living with HIV, diabetics, and tobacco smokers, and patients with chronic kidney disease, those who are on immunosuppressive drugs, the elderly, and very importantly, healthcare workers like you and me. The rates of TB among healthcare providers is almost 2 to 3 times higher than in the general population. So this basically just emphasizes the fact that tuberculosis can be a problem at the occupational setting. So we need to remember that in the occupational setting, like in prisons, in refugee camps, or people who work in refugee camps, and healthcare workers and those who work in mines have an increased risk of tuberculosis. So what do you do with these groups of individuals who may have increased risk of active TB? The World Health Organization recommends that this group should undergo active TB case finding. Now, what is active TB case finding? This is a systematic identification of people that you suspect have active TB in a predetermined target group by the use of tests, examination, and other procedures. You need to distinguish this from what is called a patient-initiated case finding, where the patient himself or herself feels unwell, comes to you, and you pick up TB. That's a good way of doing things, but it tends to delay diagnosis facilitate transmission of TB, and eventually does not pick up everyone who has TB in the community. So in a healthcare facility like the Kenyatta National Hospital, there should be a process that we call the FAST strategy, which is largely an idea to try and identify individuals with TB rapidly through cough surveillance, for example, testing those individuals rapidly, separating them from others who may not have TB and who have come to the hospital for other reasons, and treating them effectively so that you can reduce their ability to transmit tuberculosis to other people. So the FAST strategy should really be applied in virtually all healthcare settings that are large enough. Most hospitals, right from maybe level 4, 5, 6, should be applying the FAST strategy in their healthcare facilities. Let's see whether this will work. You could have people following a passive approach to TB case finding, or you could have people who are infected with TB or have active TB being identified rapidly by the healthcare system through a very concerted, deliberate effort to find these individuals. So I want to run very quickly through 3 things: diagnostic landscape, screening approaches, and treatment for both TB and latent TB infection. Let's first of all begin by the tests that are currently available for screening and triaging patients. The most common used tool is, of course, the 4-symptom screening tool, where you're using the presence of cough, fever, night sweating, and weight loss, especially in people living with HIV. This tool has a sensible sensitivity in the clinical setting, but it is rather poor at the community setting. I think the value of this tool, the 4-symptom screening, is mainly in the fact that it has a very high negative predictive value. Most people who will answer no to these 4 questions are very unlikely to have tuberculosis. The chest X-ray now has come up to the fore as a major important tool for screening people for TB. It has a high sensitivity and a reasonable specificity, but it's really important for us to know that the chest X-ray is not a diagnostic test for TB. It's just a screening tool for TB. And currently, what is exciting people in the TB world is the fact that you can use artificial intelligence to be able to automatically interpret chest radiographs and be able to triage people to either testing for TB or not testing for TB. Artificial intelligence using CAD, for example, is called computer-aided diagnostic software, is very useful in situations where there may be scarcity of radiologists. Now, this is not an issue in an institution like Kenyatta National Hospital, but it's a big issue in many parts of the country and in the world, where sometimes getting a readout of a chest radiograph might take days or weeks because there's no radiologist to read that X-ray. So there are other screening tests that are currently available and recommended by WHO, such as the point of care CRP in people living with HIV. This is different from the CRP test that we do in the laboratory. This is uses what is called a lateral flow assay. It's basically a dipstick test that can be done by healthcare workers rapidly in the outpatient setting. And if you're dealing with people who are living with HIV, you have this tool. Anyone who has a CRP of greater than 5 should be tested for TB or further evaluated for TB. You can also use your expert test for evaluating people who you think may have tuberculosis. Now let's run on to tests that are used for diagnosing the disease when the disease is there. Good old smear microscopy should ideally not be used in 2022. This test is old. It is what Robert Koch used almost 110 years ago. Yes, it has a good specificity, but depending on how it is done, its sensitivity is relatively low and very variable. You can try and improve the sensitivity of smear microscopy by doing things like concentrating the specimen or sedimenting the specimen or letting it lie there in the laboratory overnight. And that increases or bumps up the sensitivity of the test by about 10 to 20%. But this ideally, it should not be used in 2022 because it has many limitations. Cultures, especially growth rapid culture techniques such as midget are great, but unfortunately they will not be able to give you an answer as a clinician within the time that you may be interested in. With the Mycobacterium growth inhibitor tubes or midget, you may be able to pick up a positive culture within 10 to 14 days. But it's a long time for a clinician to wait for 10 to 14 days to make a decision whether to treat someone for TB or not. So cultures are really used for surveillance of MDR TB or for testing for drug-resistant TB. I think the thing that has revolutionized the way we treat TB is the so-called nucleic acid amplification test, or simply the molecular test, beginning with the expert MTB RIF assay. All of us call it expert, but expert is a platform. You can do many more things with the expert platform. And one of the things that you can do with the expert platform is to do a TB test. This was approved by WHO in 2010, and it has undergone lots of improvement. And currently you've got platforms that can give you a lot more information, as you will see in the next few slides. So WHO currently divides molecular tests into three groups. There are those that are called the moderate complexity automated tests. These require some form of some level of infrastructure that you may not find, say, in a district or what we used to call a district hospital in the old days. And maybe it might be there in a county hospital or maybe in a teaching hospital, that kind of thing. Those are called moderate complexity tests. The good thing about them is that they are high throughput tests. So you can put your 500 samples or 200 samples and run them at a single go because of the fact that they are high throughput systems. The tests that are commonly available are the low complexity automated NATs like Expert and TrueNAT and what have you, which I'm going to show in the picture in the next slide. And then you have a test that is called tests that are called high complexity hybridization tests. These are not available in our country at this moment in time. There's only one from Japan, a company called Nipro from Japan that has been approved by WHO. Very, very complicated. The hybridization technique is a very complex kind of test. So in this country, we do have both the moderate complexity tests and we have the low complexity automated NATs for the diagnosis of TB. This is just a picture to show you where these tests belong. So if you look at Expert, for example, we have the good old Expert, and now we have Expert Ultra, low complexity, and then you have Expert MTB XDR. This is a new one. It is able to give you information about the presence of Mycobacterium tuberculosis and can tell you whether that individual has drug-resistant TB, including what is currently defined as XDR TB. And then you have your moderate complexity tests. The one that's available in this country is the Roche machine that's available in this country at this moment in time. So let's move on to antigen detection test. And just to say one important thing about the urinary lipoarabinomannan test. Lipoarabinomannan is a cell wall structure. If an individual has a lot of mycobacteria, for example, if they have a mycobacteremia, this this cell wall structure can break off and come out in urine. And therefore you can detect it in urine using a lateral flow assay. It has a poor sensitivity and very variable. Its specificity is also variable. This test is currently reserved, should ideally be used in people who are HIV infected and have a very low CD4 count. And I will run through the WHO recommendation shortly. So if you look at the, if you look at the urinary lamp test, the urinary lamp test has been used as a predictor of mortality in people who are HIV infected. There are 1 or 2 clinical trials that have confirmed that this particular test in HIV infected individual can be useful in telling you who is likely to die from their disease. So these are the recommendations from WHO, that if you're dealing with patients in the inpatient setting, you can use the urinary lateral flow lamp test in people who have signs and symptoms of TB, have very advanced HIV disease, are seriously ill, and have CD4 counts of less than 200. The same recommendation is used for those in the outpatient setting, but the CD4 T cell count cutoff at that level is decreased to 100. So ideally, we should not be using the urinary lamp for anybody. You know, if you use it for me, even if I'm HIV infected and I have a CD4 count of 400, 500, this test should not be used on me. So the key messages for TB diagnosis is that let's try and use a test that is sensitive, specific, and able to confirm the diagnosis of TB, and also be able to provide information on drug susceptibility profile, especially to rifampicin and isoniazid. Preferably, we should use a rapid test that can provide results on the same day, and it should also be affordable to the patient and to the system. So these are some of the tests that are going to be coming in soon. I will not try and dwell on that. I just want to quickly tell you advances that have come out of the TB research world over the last few years. We know that we've been treating tuberculosis using a 4-drug regimen. We give we give rifampicin, isoniazid, parazinamide, and ethambutol for 2 months, and then we give rifampicin and isoniazid for 6 months. And there's been attempts for many different attempts that have tried to see whether we can shorten the duration of TB treatment to say 3 to 4 months or less. And those efforts have failed until Study 31 came about. The Study 31 was published about 2 years ago. And what Study 31 is telling us is that you can actually reduce the treatment of tuberculosis by 2 months, from 6 months to 2 months, by using rifampicin, isoniazid, parazinamide, and moxifloxacin. So you use those for 2 months, and then you continue with 2 months of parazinamide, isoniazid, and rifampicin, isoniazid, and moxifloxacin. In children, the results of the SHINE trial also led to a recommendation that you can reduce the treatment of tuberculosis in children who do not have severe disease by 2 months. So you use your 4-drug regimen in the first 2 months, and you use just 2 months of rifampicin and isoniazid. As far as I know, our rifampicin-based treatment is not available in this country yet. Drug-resistant TB, I will not bore you with this. I just want to tell you that the definitions of drug-resistant TB have failed, of XDR TB have changed. So now pre-XDR individuals with Mycobacterium tuberculosis that is resistant to rifampicin and isoniazid, but also resistant to any fluoroquinolone. While XDR TB is resistance to rifampicin and isoniazid, qualifying therefore to be called MDR-TB, with additional resistance to fluoroquinolone and at least one of the so-called group A drugs. And these are the group A drugs there: fluoroquinolones, bedaquiline, and linezolid are your group A drugs. So if an individual has got fluoroquinolone resistant and also has resistance to bedaquiline or linezolid, that individual would then be said to have XDR. The treatment for MDR-TB has changed. The injectables have been phased out. Capreomycin and nicacin have all been phased out. The focus now is on shorter bedaquiline and linezolid-based regimen. And very importantly, the WHO just 2 months ago approved what is called the BPAL regimen. The BPAL regimen is a regimen which consists of bedaquiline, pretormanid, and linezolid, with or without the combination of moxifloxacin. So BPAL-M or BPAL alone for the treatment of people with drug-resistant TB, including those with XDR-TB, a major advance for sure, which I think all of us in the TB world should be happy about. Finally, let's look at LTBI, which is defined as having bacteria that are viable but are immune controlled, and therefore there is no evidence of clinical disease. And how do you diagnose these individuals? And I think you need to remember this. You do your TST, tuberculin skin test, which is the MAN2 test, or you do your interferon gamma release assay, or now you can do what is called antigen-based skin tests. They are not yet available in this country, but they are coming soon because they were approved by the WHO about 6 months ago. Unfortunately, none of these tests is able to tell you who is likely to progress to active TB. Some people have tested PET scans to see whether they can tell you that there's some degree of activity in there that might be able to help you to know who is likely to progress. But that is unlikely to come into routine clinical practice soon. And biosignatures are being tested, but many of those will probably also not come into clinical practice soon. So who should be treated for latent TB infection? Anyone who has recent contact with someone with active TB, children under the age of 5, those who are HIV infected, those who are immunosuppressed, diabetics, and those who have chronic kidney disease. And those are the regimens you can use: 6 months of isoniazid, 4 months of rifampicin, 3 months of isoniazid with rifampicin with the doses given every week, so it's 12 doses, 1 month of isoniazid and rifampicin. And for MDR-TB contacts, the WHO currently recommends that you can use levofloxacin. I think I'm going to stop there because I think I've run out of time, and I thank you so much for listening. Asanteni sana. Are you still there?
Yes, we are. Thank you very much for the very nice, comprehensive presentation. I'm sure we have all learned the 1,000 plus participants, which was scattered all over the country, have learned quite a bit about tuberculosis. I also see there are lots of questions, so I think the team at KNH, please, you'll guide us there with the questions. I'm not able to see them. Nelson.
Thank you so much, Dr. Thank you so much, Professor, for that informative session. We really appreciate. There are comments saying great presentation from the participants, and a few questions which I'll read through. The first question is, do we already know how COVID-TB co-infection affected disease progression? Professor, kindly.
Very limited data for sure, but the general direction seems to be that people who are infected, even if you have just a positive TST or something, people who are infected with TB without active TB disease may have a poorer or more severe disease and therefore a poorer outcome. And when they get COVID-19, and COVID-19 might also stimulate activation of tuberculosis. So it's bidirectional, so much so that currently WHO and others recommend that anyone with COVID-19 should also be tested or screened for TB.
Thank you so much for that answer. The next question is kindly define latent tuberculosis and how to treat it.
So, like I said in the talk, latent tuberculosis is a condition, is a situation where an individual is infected with Mycobacterium tuberculosis. If you were to sample each and every organ of that individual and culture that individual's organs, you will get viable microorganisms in culture in this individual. So they have viable Mycobacterium tuberculosis sitting somewhere in their bodies. However, they do not have, at that particular moment you're seeing them, they do not have signs and symptoms of TB. So they are completely well. Now, you don't have to treat most of these individuals. However, if they have risk factors for progression of that infection to active TB disease, then they need to be treated. How do you know that this individual has infection with Mycobacterium tuberculosis? You can use one of three tests. You can use the Mantoux test in this country, you can use the Xray test, and you can use the so-called antigen-based skin tests that are going to be coming very soon. Okay, those are not available now. So at this moment in time, you will only have the Mantoux test or the Xray test. Now, if I have an infection and I have a risk factor for progression of that infection to disease, I should be treated with the regimens that I just mentioned: 6 months of isoniazid, 3 months of rifampicin and isoniazid, or weekly doses of rifampicin and isoniazid for 12 weeks.
Thank you so much, Professor. There are other questions that tie into that. How long does TPT confer protection from TB? And how many times can one take the dosage? Can breastfeeding women be given TB preventive therapy?
Okay, let's start with the issue of how long should people is the protection sustained. The studies, people are no longer doing these studies anymore, but in the early 90s, when some of us were just beginning to enter into this field of TB, studies did show that in people living with HIV, the protection is lost at about 18 months or so. And it's lost because of re-exposure to TB. And therefore, some people started recommending that maybe you should redose these individuals every 2 years or so. One study done by, it's called the Botusa study, that was done in Botswana, looked at long-term treatment with isoniazid. These individuals were given 36 months of isoniazid, and others were given the usual 6 months of treatment. And there was better protection in the longer, in the group that were given longer treatment than those that were given 6 months. So in HIV-infected individuals, there may be need, if you're living in a place where there's a lot of pressure to get reinfected, there may be need to redose individuals every 2 or so months, or keep them on the long term on isoniazid. And one of the things that is happening in that field is the development of a combined tablet of cotrimoxazole and isoniazid that can be taken the way people take cotrimoxazole for literally for life. So that's for HIV infected and duration of protection. For pregnant women and breastfeeding women, they probably should be given, they should be given preventive therapy if they have risk factors for progression to active disease. There are no strong data to show that they are, for example, poor maternal or fetal outcomes. I didn't present that data, but it's reassuring that there are really no significant fetal outcomes. However, for people who are pregnant, it may be, if they are not, if they are well, it may be better to wait until they've delivered before you give them TB preventive therapy. I can't remember what the other question was about.
Professor, you've answered both questions. There is another question here asking, what is the sensitivity of a chest X-ray in TB diagnosis? Does it still have a part? And also, given that most of the diagnostic tests available to us are dependent on the available bacilli in sputum, which is related to the ability to have an immune response, should we encourage more clinical diagnosis for people living with HIV?
No, I think I would start with that. We should not be diagnosing people on a clinical grounds. As much as we can, we should try and confirm the diagnosis. There are many mimics of TB, and you do not want to place everyone on anti-TB treatment on clinical grounds alone. So every individual, wherever possible, should be tested for TB. Your chest X-ray, like I said, has a high sensitivity. Most people with TB of the lung will have an abnormality on the chest X-ray. Very few people will not have an abnormality on the chest X-ray. I was just reviewing one PhD thesis from a university in Ethiopia, and they did a lot of X-rays, thousands and thousands of X-rays. And among those who had normal chest X-rays, only about 2 to 3% had positive culture. So it's rare for someone to have a normal X-ray and still end up with a positive positive TB test. But the problem with chest X-ray is that it is not specific. If you see a shadow, even if it's cavitating and it's fibrosing, all those things, there could be other things that are causing that problem, and it's not necessarily TB. So you use the chest X-ray for screening and triaging. You don't use it as a diagnostic tool.
So much. There's so many questions. I think this was a very timely presentation. There's a question here asking if Mantoux test is used to diagnose extrapulmonary TB, e.g. in ENT sites.
No, Mantoux test is a test for infection. If you go to, I'm in Nairobi, I don't know where the person who is asking that question is coming from, but if today you went to the KenCom bus stop and you asked everyone to come and line up and you do a Mantoux test on them, 50 to 60% of them will be positive. Are you going to treat them for active TB? It is a test for infection, it's not a test for disease. And it really should not be, especially in adults, it should not be used to make a diagnosis of TB, not at all. Use your bacteriological test, your expert or whatever, use your clinical acumen. You are allowed to look at individuals. If the individual is coming to you, they have fevers, they are losing weight, they are night sweating, you've done your TB test, it's negative, and you are so convinced this individual has TB, you are allowed to treat that individual for TB, but don't bother doing Mantoux test on them.
Thank you for that answer, Professor. There are two questions here relating to the county. I know we have Mrs. Mweni, who is representing the TB county point person. There's a question that is asking when the new registers are being rolled out in relation to MDR TB treatment, as well as what is the county currently doing on TB defaulters?
I think that goes to Mweni, not to me.
Thank you, Daktari. Yes, thank you. We have the new registers. I think we need to get in touch with the that we can link them up. So the registers are available both for the drug-sensitive TB and the drug-resistant TB, and also for contact management and TPT. So we have enough registers. Kindly just link up with us or the sub-county TB coordinators so you are able to get it up. For our defaulters, lost to follow-up, we have a system, we have a partner supported the CSOs that are doing follow-up. I think this is a facility that has not been linked. We'll also get in touch with you so that we can see how best we can assist those who have defaulted of treatment. We have a system that we usually do follow-up to this client and bring them and also give them outcome. So I think get in touch with us so that we can get to know where you are and link you up with the CSO that are supporting the community TB mechanism. Thank you.
Thank you, Mweni, for that comprehensive answer. The two last questions for Professor. There is a participant asking, how does the sensitivity of GeneXpert compare to TB quantiferon? And how is the availability of IGRA test and quintaferon in Kenya?
Okay, again, I will say this, and I'm happy there's 1,000 of you. Your IGRA test is not a test for TB disease. It is a test for TB infection. By the way, this is how you do your IGRA test. You take lymphocytes of this individual and you incubate them with the antigens from Mycobacterium tuberculosis. If the fellow's immune system recognizes the antigens, the T lymphocytes produce interferon gamma. That's the principle of that test. But it's a test for TB infection. It's not a test for TB disease. You should never compare it with XPAT, which is a test for TB disease. It looks like we need to do more and more of this. People have, I don't know whether KNH can repeat this. Dr. Atina, you might have to do this again. People are coming in and asking the same questions, which means we have to keep drilling this information to people so they can understand the differences between infection and disease.
Okay, thank you so much, Professor. I think some of the questions that are here you've already answered in your presentation. So I will hand over the meeting back to Dr. Atina. Dr. Atina, kindly.
Thank you. I think Professor Chakaya has done an excellent job. As usual, I think I didn't have time to say that probably the most passionate speaker on TB I know in this country. And, you can see what is brought to the table. So, Professor, thank you. I think we'll consider maybe adding more webinars on TB. I'm also surprised. In fact, initially when I was asked about this, I didn't know there would be enough interest. But I'm impressed by the attendance. Thank you for all you have done to us. And as I was going through this stuff earlier on, I was very shocked to realize that TB is such a huge thing. Even in our own respiratory society, I know we talk a lot more about asthma and the other things, but if you look at the numbers, you get surprised. 10 million every year. We lose 1.5 million, so the numbers are really huge. And I'm glad we are highlighting this. KNH is the leading center in this. That's one of the reasons I was late. I was doing around in the MDR ward where we have patients in very poor conditions, which is largely a result of what we are doing out there. The patients ending up with MDR and XDR. So I think we'll leave it here because of time. The next time, I guess we'll invite other speakers to help us through with the rest of the other forms of TB. TB is a huge area, not just what we have done. It's not just what is it called? This thing we are discussing today, the screening and case finding. So thank you very much. I think if there are no other comments from the team in Nairobi, we'll end it here.
Thank you so much, Atina. Thank you, Prof, for that presentation. Yeah, we now bring it to an end. You are welcome for our upcoming sessions. Tomorrow we have this pesticide toxicology. We have a session on Thursday on respectful maternal care. You're all welcome. For the sessions, you'll be able to watch them at our website, at the KNH website. So we really do appreciate. Do have a good afternoon, everyone.
Thank you.
Thank you.